All right, everybody. Welcome to SunCloud Health. My name is Dr. Kim Dennis. I'm the co-founder and chief medical officer here. We are a multi-level of care treatment center that serves adolescents and adults with multi-morbid disorders, usually more than co-occurring, but mood disorders, anxiety disorders, eating disorders, and addiction, as well as trauma of all sorts. We are located in the Chicagoland area and have an office in Gaithersburg, out in Maryland as well. I'm delighted that you all are joining us this morning, whether you're remote or here in person. And I have the distinct honor of introducing somebody who is a mentor of mine, a hero of mine in the field, and somebody whose work I've been following since before I graduated from my psychiatry residency. Dr. Timothy Brewerton is an affiliate professor of psychiatry and behavioral sciences at the Medical University of South Carolina, or MUSC. This is in Charleston, and he has a private practice as well as a research practice. He is a consultant and advisor to us here at SunCloud Health, as well as Eating Recovery Center, Pathlight Behavioral Health Centers, and Montanito and affiliates. He's board certified in general, child and adolescent, and forensic psychiatry, as well as addiction medicine. He is Distinguished Life Fellow of the American Psychiatric Association, Distinguished Fellow of the American Academy of Child and Adolescent Psychiatry, a founding fellow of the Academy of Eating Disorders, a founding member, former president of the Eating Disorder Research Society. He's authored greater than 185 articles and book chapters, edited 2 books, and presented over 250 scientific presentations at national and international conferences. Dr. Brewerton is also the executive producer of a documentary about child maltreatment, eating disorders, and dissociative identity disorder. If you have interest in that, you can find out more about it at www.sylviadoc.com. We were lucky enough to have a screening of it last night. It's amazing. Dr. Brewerton has been instrumental in exploring the overlaps between trauma, PTSD, and eating disorders, and promoting integrated treatment approaches for eating disorders and related comorbidity. His research profile can be viewed at www.researchgate.net, profile Timothy-Brewerton/research. And he is a big deal. He's a big deal. So we are blessed to have him here today. I'm both personally and professionally extremely grateful to be here at this talk today and to have you here.
Thank you, Kim.
Thank you.
It's a real honor to be here, and thank you all for coming, and thank you all at home or wherever you are for tuning in. So I'm here to offer my perspectives on eating disorders, PTSD, and comorbidity, and why integrated treatment is not only indicated, but makes the most sense based on the current science. And some of the websites that Kim mentioned are there for your information. So these are my disclosures, most of which have been mentioned already. And these are the topics for today. I'm going to talk about what is trauma, and in particular the 3 E's of trauma. I'm going to be talking about trauma and eating disorders and its relationship to PTSD and comorbidity, and a new term that I like to use, multimorbidity. We're way far beyond dual diagnosis. I'm going to talk a little bit about the relationship of all of that to food addiction. I'm going to talk about mechanisms leading to morbidity and mortality and guidelines for integrated treatment planning, and the importance of trauma-focused therapies, particularly with an emphasis on cognitive processing therapy. And then I'm going to show you some evidence for integrated trauma-focused treatment. I like to start off with quotes. I love quotes. This one applies to my presentation. We know that people once thought that the earth was flat and the center of the universe. Growing up, many questioned evolution and later global warming and climate change. When I was in medical school, the 1976 Friedman and Kaplan textbook of psychiatry stated that incest was very rare and didn't occur more often than 1 in 1.1 million people. The reality of childhood sexual abuse and incest is very real. I think all of you are aware of that at this point. PTSD and bulimia didn't exist in American psychiatric nomenclature before 1980, while homosexuality was considered a disorder. When I was a resident in psychiatry, I was taught that kids couldn't be depressed. There was no such thing as major depression in children. And some people still believe that childhood onset mania does not exist, even though I've seen several cases. Multiple personality disorder, now dissociative identity disorder, was thought to be a fantasy, and the idea that trauma played a role in eating disorders was considered an outrageous idea by many. And then if it was present, many in the field believed that one had to treat the eating disorder first and put trauma-related issues on the back burner until mañana, and mañana never came for most because they couldn't effectively treat their eating disorder without treating their PTSD. Food addiction is the new lightning rod, which I will be talking about later. And we all have been aware of a research practice gap, that it takes on average 17 years between the time something is published in a peer-reviewed article and the time that it's accepted into clinical practice. Sometimes longer, sometimes shorter, but that's the average. The 3 E's of trauma are, in my view, the best way of understanding what trauma is. Many people think that it's just an event, but it's also very much the person's experience of the event as well as the resulting effects of the event. Experience is determined by a wealth of factors, including age, genetics, gender, culture, and social support and context. And is the development of an eating disorder one of the potential effects of trauma? A wealth of data suggests that the definitive answer is yes. So I'm going to show you some data, not all, because I'd be here all day. That's how much data there is, that there is a higher rate of trauma and traumatic events in eating disorders. One major study, it's a meta-analysis that I had the pleasure of being a part of, was published in Psychological Medicine. And the prevalence of child maltreatment, never mind other forms of treatment, but just mistreatment, but child maltreatment, with an N of over 35,000 people, over 13,000 eating disorder, 15,000 controls, and the first study to also include psychiatric controls showed that eating disorder subjects with child maltreatment compared to those without had significantly more likely these 5 things, and you're going to hear this theme throughout the talk today. They had more comorbidity, they had more suicidality, they had an earlier age of eating disorder onset, a more severe form of the disorder, and greater frequency of binging and purging. That's a take-home message. And child maltreatment was, regardless of the type of treatment, was present in all types of eating disorders. And the severity parameters were there in a dose-dependent kind of way. So the higher the dose of trauma, the more severe the eating disorder and these characteristics of the eating disorder. Another study published later that year in 2017 with a sample size of over 36,000 from the National Epidemiological Survey on Alcohol and Related Conditions, which included even more types of traumas. The usual types of traumas, along with harsh physical punishment and intimate partner violence, showed, again, all childhood maltreatment forms were associated with all eating disorders. And they did not, unfortunately, report on rates of PTSD. But there are studies that do show higher rates of PTSD in eating disorders. I've been a part of some of those. These are 2 national representative samples that show significantly higher rates of lifetime PTSD in bulimia nervosa. One is in the National Women's Study, one is in the National Comorbidity Survey replication. We also see higher rates in binge eating disorder compared to those without an eating disorder. And to bring home the 3 E's point, just because you've had a trauma doesn't mean that you're going to develop an adverse effect. This is data from the National Women's Study showing the rates of bulimia in those who've been raped who develop PTSD with a rate of 10.4 versus those who were raped who did not develop PTSD. Not everybody who's traumatized develops an adverse experience. They're no different than those who had never experienced a rape. So this really brings home, I think, the fact that everybody reacts differently, even to the same kinds of trauma. The National Comorbidity Survey, these are the lifetime PTSD rates, and you see the highest odds ratio is in bulimia nervosa. If you've had PTSD, the chances of developing bulimia nervosa are 10.2 times higher. Very similar to what we found in the National Women's Study. And then higher in binge eating disorder, higher with any binging at all, even if in the subclinical forms of binge eating disorders or binge-related disorders, and a higher but non-significant higher rate in anorexia nervosa, mainly because of the low sample size in this study. So trauma, PTSD, and eating disorders have been associated, and the association has been demonstrated in a variety of samples in both treatment and non-treatment seeking individuals, people of various ages, genders, sexual orientations, ethnicities, and from different countries and continents, as well as socioeconomic classes. It's been reported in North America, South America, Europe, Middle East, Australia, New Zealand, India, Asia, including these countries there that I've listed. Traumatic events, for the most part, when it's been reported, tend to predate the onset of the eating disorder symptoms. Not in all cases, but in the majority of cases. Trauma also occurs after the onset of eating disorder, so it's both and. And I would point out the 3 Ps that trauma and PTSD serve as predisposing factors for the development of eating disorders, precipitating factors for the development of eating disorders, as well as perpetuating factors. But let's not forget about the other 2 Ps, prevention. There are a lot of implications for this, and you don't really hear much about preventing child abuse as a preventive measure for eating disorders. And then palliation is what we're really talking about today. How do we treat it when it has happened? How common is it? Well, the pooled lifetime prevalence rates of PTSD and eating disorders in the highest quality studies, about 25%. Higher in bulimia nervosa, 37 to 45%, 21 to 26% in binge eating disorder, up to 23% in anorexia, and lowest in anorexia restricting, but still higher than what you see in the general population. Conversely, higher rates of eating disorders and symptoms are seen in patients with PTSD compared to the general population. And then higher PTSD rates up to 50% are reported in all types of eating disorders, both adults and adolescents who were admitted to residential treatment, especially those with bulimia nervosa, binging and purging anorexia nervosa, and other specified feeding and eating disorders. These are 2 publications that our group has done. The top one is in adults, 642 residential treatment patients, 49.3% met criteria for PTSD. In the lower paper, these are 647 adolescents, 35.4% met definite criteria for PTSD. So we see this in all ages, and there is a number of things that you can say about the clinical significance of the combination of eating disorder and PTSD in residential treatment centers. More severe eating disorder symptoms, greater anxiety symptoms, greater depressive symptoms, worse quality of life measures, higher number of trauma types, or trauma dose, if you will, less propensity toward restricting anorexia, and higher BMIs and BMI percentiles for age and sex in children and adolescents. The age of eating disorder onset matters. Onset during childhood, self-reported eating disorder onset, these are in adults, is associated with higher trauma dose, higher rates of PTSD, and severity of illness in residential cases. 76% of adults who self-reported childhood eating disorder onset between the ages of 5 and 10 met criteria for PTSD, compared to 45% of those with self-reported onset in adolescence, 11 to 17, and 31% with a later onset during adulthood. The higher trauma dose, BMI, severity of eating disorder, major depression, and state trait anxiety, and worse quality of life, as well as more prior eating disorder-related inpatient and residential treatment admissions were found in the early onset group. We've also reported that there are significantly higher rates of PTSD in the LGBTQ plus population. This is a study of 575 adults admitted to residential treatment. 24% were sexual and gender minority individuals. And they had not only higher rates of PTSD, but higher number of total lifetime traumas and certain higher frequencies of distinct traumatic experiences, particularly unwanted sexual experiences, sexual assault, physical assault, and severe human suffering. So LGBTQ patients with PTSD reported also significantly greater eating disorder, major depressive, and trait anxiety symptoms. So this is a group that really engenders special attention. There's more OSFED in this group, in the sample that we studied, and less anorexia nervosa restricting type. So it's common in individuals with eating disorder and PTSD to report multiple traumas or trauma types, as you've seen so far. And these higher trauma doses are associated with greater severity and higher rates of comorbidities. And it's been shown or talked about in the literature that if you have both child trauma and adult trauma, people call that complex trauma. Bessel van der Kolk called it developmental trauma. He tried to get that into the DSM-5 and was not successful. They tend to have more complicated courses of illness, higher dropout rates, and worse outcomes following treatment. A number of studies are showing that. And that begs the case for complex PTSD, which is not in our current nomenclature of DSM, but it is in the international nomenclature now. So in addition, people with both eating disorder and PTSD tend to be more impulsive, prone to re-victimization as a result, and subsequent perpetuation of PTSD, which tends to be a chronic disorder. This is Marilyn Cloitre, as well as Judy Herman and Bessel van der Kolk paper, 2009. It shows very nicely how as the number of childhood traumas increases and the number of adult traumas increases, the complexity of the symptomatology also very much increases. PTSD, this is a study from the National Comorbidity Survey, the very first survey. This was published in 1995 in the Archives of General Psychiatry. It showed that at 10 years, PTSD was a chronic disorder, persisting in about a third of individuals. And several long-term studies since then have confirmed that PTSD tends to be chronic in about a third of individuals. This has been shown in studies from the World Health Organization. It's been shown in veteran populations, and it's important to realize that. So there's higher comorbidity in PTSD. Not only do we have eating disorders that come as a result of big T trauma leading to PTSD, there's a whole slew of psychiatric disorders that are also related. Not just eating, but mood disorders. Over 75% of eating disorder patients admitted to residential are diagnosed with a concurrent mood disorder. In one study that we did, 8 or 9% had bipolar disorder and the rest had major depression. And this is not counting dysthymia or lesser forms of depression. So mood disorders are the rule rather than the exception, particularly when you have concurrent PTSD. Anxiety disorders also are highly comorbid with both eating disorders and PTSD. And then dissociative disorders. Very high frequencies of eating disorders and behaviors have been seen in dissociative identity disorder patients. Beginning with Breuer and Freud described alterations in feeding behaviors and anorexia to the pitch of rejection of all nourishment, quote unquote, reported in 1893. And other investigators, Frank Putnam among others, have noted this. And there are conversely high frequencies of dissociation and dissociative disorders in eating disorders, especially bulimia nervosa, and in non-clinical samples with eating disorder pathology. Some of these studies were reported by the likes of Kim McCallum, founder of McCallum Place, Jim Locke, who is one of the major authors of family-based treatment. They've been reporting this association for actually decades, since the mid-1980s. We also know that somatoform disorders are higher in relationship to eating disorders and trauma. We reported high rates of unexplained headache in people admitted to residential care who have PTSD compared to those who don't. This was a paper published last year. We also have high rates of personality disorder features, particularly cluster B personality features in association with eating and trauma and PTSD. Disruptive behavior disorders and ADHD, very much higher. There's a bilateral or bidirectional relationship between ADHD and PTSD. ADHD leads to more PTSD, but PTSD also leads to more ADHD. And there's a literature that bilaterally that goes that way. We know that other forms of disruptive behavior are also a result of trauma and PTSD. And then there are impulse control disorders. And then, of course, substance use addictive disorders. Let's not forget about SUDS and substance-related disorders. And we have the process or behavioral addictions, gambling, kleptomania, hypersexuality, internet gaming, and shopping, very high in eating disorder populations. And of course, OCD, how could I forget OCD? A lot of people don't know that there's a literature about trauma playing a role in initiating OCD and perpetuating OCD and making OCD worse. Those with OCD and PTSD have a more chronic and severe course. And then, of course, there's autism spectrum disorder, right? You've got to remember that. There's a whole burgeoning literature about the relationship of autism spectrum disorder and eating disorders, particularly anorexia nervosa. And I'm not saying that trauma causes autism spectrum disorder, but people with autism spectrum disorder are subjected to a lot of abuse and trauma and bullying and develop PTSD not infrequently. And then we have, of course, food addiction, which is not part of the DSM, but it's nevertheless a valid and reliable entity. It's been established now for many, many years as a thing. Even though it's not in the DSM, but you know, bulimia wasn't in the DSM, binge eating disorder wasn't in the DSM. A lot of things weren't in the DSM once upon a time. That doesn't mean that it's not a valid conceptualization or phenomenon. In fact, in some cases, particularly in the eating disorder world, mentioning food addiction, and more properly now ultra-processed food addiction, is really anathema. And I know that word because I grew up Catholic. Anathema is synonymous with abhorrent, hateful, odious. It's amazing the reaction that some people in the eating disorder field have to this notion. It's really quite amazing. Repugnant, repellent, offensive, right? Someone or something intensely disliked or loathed. And I've seen this happen to some very famous and competent researchers who have tried to present scientific data and have a discussion about this. So it's amazing, despite the fact that over the last decade, there has been increasing research interest and a steady growth of scientific publications on food addiction, and it continues to be of major interest to clinicians and researchers alike, as well as to the lay public. And if you follow that curve up and off the square into 21, 22, and 23, you see that it's only increasing. It's not going down. More and more scientific interest in this phenomena is happening. And it doesn't mean that we know exactly what to do about it, but to acknowledge first and foremost that it is a thing, it is a phenomena. And it's been shown in animals and humans many, many times now. And it's important in our understanding about eating disorders and trauma. And this is a study basically by Susan Mason using over 57,000 adults. I love these sample sizes, right? This is from the National Nurses Study, Wave 2, back from 2009, and has the combinations and trauma dose of sexual abuse and physical abuse increases, you have more and more or higher and higher odds ratios for meeting criteria for food addiction using the Yale Food Addiction Scale, which has been validated, by the way, in many, many, many languages now around the world. This is not just an American phenomenon. So a really interesting paper that came up in 2011 was this paper by Hirth and colleagues out of Texas, and it was a cross-sectional data from over 3,100 females, 16 to 24 years of age, attending 5 publicly funded clinics in Texas. And they found that PTSD symptoms were associated with an increased frequency of consumption of fast food and soda, as well as unhealthy dieting behaviors or eating disordered behaviors. But there was no link with BMI. And the editors asked me to write an editorial on this paper, which I thought was an incredible paper. And it was the first study to demonstrate a connection between PTSD and the frequency of ingesting particular types of foods, in this case, sugary sodas and fast foods, and what we now call NOVA-4 ultra-processed foods. And in my view, it was a validation of the self-medication hypothesis of PTSD. We're all familiar with the self-medication hypothesis of addiction, which has been proven many times over now, that people often medicate to feel better and to numb their dysphoric symptoms from whatever, and PTSD is very, very high in the substance abuse addiction world. So people who were victims of interpersonal violence are preferentially selecting highly palatable foods, which we know stimulate dopamine big time and alter the brain, as a way to dampen arousal, facilitate numbing and avoidance. And sometimes it gets to the point of addiction. And this has been well defined and described by Ashley Gerhardt and colleagues. This is another paper in JAMA Psychiatry, one of the most prestigious journals in psychiatry, 2014. This is not new data. Cross-sectional analysis of over 49,000, again from the National Nurses Study, and the prevalence of food addiction increased with the number of lifetime PTSD symptoms. And women with the greatest number of PTSD symptoms had more than twice the prevalence of food addiction as women with neither PTSD symptoms nor trauma histories. The PTSD symptoms were more strongly related to food addiction when symptom onset occurred at an earlier age. Again, we have this recurrent theme of the earlier the age of the onset, the worse this relationship is. And this graph shows you that when the PTSD symptoms began before age 10, there was a very high prevalence ratio or odds ratio of having 6 to 7 PTSD symptoms. And then also significant in adolescence, and then it goes down as PTSD onset decreases with age. Very compelling data. Another paper by Karen Mitchell and Erica Wolf. These are no slouch researchers at the National Center for PTSD. I know Karen, I've worked with her. Very highly competent individuals. They are researching PTSD and food addiction, and they showed in this study in nearly 700 trauma-exposed veterans that PTSD symptoms were directly associated with both eating disorder and food addiction symptoms, as well as emotional suppression and cognitive reappraisal. This is hard to follow, but the point of this is that PTSD, this is the final common pathway after plugging in all of the different variables. This is what you end up with in terms of the final pathway analysis. And you see very powerful, highly significant relationships between PTSD and eating disorder symptoms, of course, at the bottom, but also food addiction symptoms at the top. It's all and, it's both and. And then strong relationships between eating disorder symptoms and food addiction symptoms. And it's linked to emotional suppression. So it supports this self-medication hypothesis idea that people are using food, not broccoli, but highly palatable foods to self-medicate and alter their consciousness. Now, on the other hand, lacking in the literature is a description of a more comprehensive approach to assessing food addiction. The eating disorder field has a point, and we do have to factor in the issue of restriction. Restriction is a huge, big deal, and it's a factor that contributes to and precipitates a lot of eating disorder behavior. Okay? That's a given. That's been shown. Dietary restraint is a problem. The problem is that people often equate food addiction with caloric restriction, and they're not the same. And so we do need to consider dietary restraint that David Wiss and I argue in this paper, separating the signal from the noise. But identifying the presence of symptoms of other psychiatric disorders is key. Again, the comorbidity issue I put to you is really important. And so that will help you determine whether you have a true positive food addiction, the signal, the real signal, versus the false positive or the noise. And restriction can induce some noise in the system because the Yale Food Addiction Scale doesn't measure restriction, right? So you need a measure of food addiction, you need a measure of eating disorders, and you need a measure of PTSD. And you need a measure of depression and probably some other comorbidity that I'll show you. There are true negatives, of course, where you have people driven by restraint. And the fact that as many as 50% of patients with restricting anorexia nervosa who endorse food addiction. So this is kind of David Wiss and I's answer to that you can distinguish the signal from the noise. So when you've got all of this symptomatology together, you get what many people call complex PTSD. It's a conglomeration of symptomatology, and sometimes it's really hard to tease that apart. If you're a clinician, it's quite overwhelming. And again, complex PTSD is a controversial condition. It's not in the DSM. Doesn't mean it doesn't exist. It is in the ICD-11 though. And then you add on to all of that, all the wealth of medical complications that we know come from adverse childhood events and trauma. There's a wealth of literature showing neurological and cardiovascular and every system in the body pretty much can be adversely affected as a result of trauma, particularly early chronic trauma. And people out there who are doing primary care are seeing these disorders, but they're not trauma informed. And we need to move toward a much more holistic trauma-informed practice throughout all of medicine and psychiatry and mental health. So if it makes you want to scream, given the complexity, I get it. But imagine our patients who are suffering with some variation of this new term that I discovered in the literature, multimorbidity. When I was in training in 78 to 82, dual diagnosis was like the big deal. Oh, wow, you have two conditions. Wow, how complicated and overwhelming, right? We're way beyond two conditions now. Who doesn't have two conditions, right, if you have one? So One of the pieces of work that I've recently published has to do with how do we interpret the ACEs. Everybody familiar with ACEs, Adverse Childhood Experiences Scale? And this pyramid, perhaps you've seen before. It's been put out by the CDC for many, many years. The first paper on ACEs was in 1998, showing that it was linked to all of the major causes of disease and death in the United States. So what I've done here is I've taken multiple published sources from around the world that have confirmed an association between ACEs and other traumatic events and with eating disorders and related adverse outcomes, including higher morbidity and mortality. And so this is a narrative review, and I invite you to check this paper out if you're interested. It's open access, so it's freely available, and you can read the literature about it. And it goes through the purported mechanisms through which childhood maltreatment and other forms of violence toward human beings influence the, influence the health and well-being of individuals who develop eating disorders throughout the lifetime or the lifespan. And then I'm also including relevant literature on PTSD when applicable. So, how on earth do you get from adverse child experiences to early death? And that was a bit of a mystery back in 1998. But there's been a ton of research since then that have filled in a lot of the blanks. And they've also added generational embodiment, which includes genetics and now epigenetics, which is a major advance and paradigm shift in the field to help us understand historical trauma and how that influences people. And then social conditions and local context. And it's that kind of fertile ground upon which adverse childhood experiences occur. They don't just appear out of a vacuum. And it disrupts neurodevelopment. How does it do that? By altering hormones, transmitters, peptides, and the functional connectivity in the brain. It majorly alters the way the brain functions. And that leads to socio-emotional and neurocognitive processing difficulties. Guess what? Those have been identified in spades in eating disorders independently, and they've been identified in spades in people who with PTSD. And if you have the combination, you have even a worse case scenario in terms of these emotional cognitive processing difficulties. People with PTSD have memory impairment. A lot of people don't know this. They have memory impairment as severe as people with temporal lobe epilepsy. And then you move on to the adoption of health risk behaviors. What are those? Dieting, binging, purging, substance use, exercise, self-harm, and other forms of impulsivity, all of which alter the brain. All of those behaviors alter neurochemistry in known ways and perturb the system that's already vulnerable and compromised, to continue to have downstream effects that ends up looking like medical comorbidity complications, not to mention the interpersonal and family dysfunction that comes as a result of that, and less social support and connection. It pushes people away out of your life. And then, God forbid, fatal complications. Half of people with eating disorders kill themselves. And there was a major article in the American Journal of Psychiatry a year or two ago that most of those cases are using substances in addition to their eating disorder to kill themselves. So you've got eating disorders, addiction, substance use, PTSD, trauma, and suicide and death, right? Which is what we're all here in part to prevent. We didn't get here overnight. This is all evolved because of research. And a lot of people don't realize that what you know now and what you've been taught now is because of hard researchers and new data and the evolution of science, which is completely continuing to change. And what you know today and I know today may be very different next year or 5 years from now, right? Because it's evolving and it's changing, and we need to be open to that and understand that, right? To new ways of thinking and new data to challenge our beliefs. We're not, patients are not the only ones with cognitive distortions. We also have false beliefs and biases and false ideas that we think are true, but they're really not. They're assumptions, right? And we have to know that in order to move forward. So doing research, doing clinical work that is data-driven, I really want to put a plug in for, because it has not only clinical value and allows you to deliver much better care for treatment planning, for case conceptualization, and also, unfortunately, for insurance companies. It's harder to argue when you send them assessment instruments that prove your point. It's harder to argue when you send them research papers, peer-reviewed papers that support what you're doing. Because they don't know that literature, I guarantee you. You're informing them. And then feedback at the site or the region and at the program level, it really helps deliver better care. And I think patients appreciate it, and it conveys, again, that you care to give them excellent care, state-of-the-art care. And then you're contributing to the world and the literature. You're helping us to understand these symptoms and these disorders better, because we understand them better today than we did when I trained, I guarantee you, and that's been an evolution. And so contributing to the field is really, I think, a real added icing on the cake. And then you can improve your programs as well as contribute to the literature. And so there are all kinds of assessments. There are self-report assessments, there are interview assessments. These are some of the ones that we've used in our research. But two at the bottom, if you're interested in becoming more trauma-informed, are very, very important. And those are the life events checklist for DSM-5 and the PTSD symptom checklist for DSM-5. And you can find an array of information about assessment instruments at this site, which I give to patients and professionals alike, ptsd.va.gov. Memorize that. ptsd.va.gov, and there's a professional section and there's a patient section where I assign as homework for patients to go to this website and read everything they want to and can about PTSD. Because psychoeducation is super important in part of the treatment. This is the LEC-5, and basically it asks about 17 things, 17 events that either happened to you or you witnessed or you learned about, and whether it's part of your job and so on. And you can go to that site and look at that. And then you have the PCL-5, which is really simple to give. It takes 5-10 minutes to fill out. And it's divided into all of the clusters of the DSM-5 PTSD criteria. B, C, D, and E. Boom, 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 boom. Right? There are 20 criteria. There are 20 questions related to the PTSD criteria. And you can go over this with them afterwards. So it's quick and easy. And it makes your job easier. And it's not only a good way to assess people for it, but it's a good way to follow response to treatment over time. So let's move on to integrated treatment guidelines. And it used to be that, treatment for eating disorder, treatment for PTSD, they never met in the middle. And treatment programs that did eating disorder didn't touch PTSD or trauma. We don't want to hear about that. You can do that later when you're outpatient. And then PTSD programs, eating disorders, that's not important. You can do that later as an outpatient. And you've maybe heard some things that people say. She's too sick right now to do the trauma work. That was an excuse I heard a lot. We need to stabilize them at residential so then they can do the longer term trauma work in outpatient. So this is just avoidance, plain and simple. And avoidance from treatment providers perpetuates avoidance. because this is not something the kind of work that people are chomping at the bit to do. And what are the problems with sequential models of treating eating disorder, PTSD, and comorbidity? Well, people may spend 30, 60 days in an eating disorder program and they never really make it to the second or third treatment. Who wants to go to another treatment program with different therapists and have another treatment episode and take time out of work and not be with your family? And they may have a completely different treatment philosophy, and not to mention the expense and the inefficiency and how much it exhausts resources. And so a lot of times their symptoms get exacerbated. And PTSD symptoms are perpetuating factors. And again, avoidance perpetuates avoidance. And if you just focus on the PTSD without addressing the eating disorder, that's not likely to be effective. And people have really failed until recently to recognize the intertwined nature of these conditions. So you can make a strong case for an integrated model that eating disorders and comorbidities are in part a result of the trauma in PTSD, PTSD being the major predictor of comorbidity, hands down more than anything else. PTSD symptoms are perpetuating factors, and reductions in PTSD symptoms are more likely to lead to reductions in eating disorder, PTSD, and comorbid symptoms than the reverse. And then we have to factor in patient preferences. This is always, every step of the way, a collaborative endeavor. It's not, you can't ram this down people's throats. It has to be a collaboration. And people get to decide, because there's not just one path, right? People have choices. So what do you do if you're a provider and you want to deliver good treatment? And so you may go to practice guidelines, right? Well, guess what? The eating disorder practice guidelines don't say a whole lot about comorbidity, and they don't address eating disorders and PTSD pretty much at all. And the same reverse is true for PTSD practice guidelines. They don't even mention eating disorders, right? So this perpetuates what's called a silo effect, with each set of guidelines not addressing the complexity of the other comorbidities and the complexity of the kinds of patients that you see, particularly in higher levels of care. And you get a lack of integration between providers, and people often don't talk to each other. I know psychiatrists are supposed to talk to the therapist and supposed to talk to the primary care doctors, but in my experience, they never do. They don't even bother to get old records. I mean, it's really pathetic because they're not getting paid for that. And so a lot of times it leads to really shoddy care, and it inadvertently promotes chronicity and multimorbidity. And I think, again, as I said, it's particularly relevant for those in higher levels of care and with rates as high as 50%, and then the other several percent that have sub-threshold PTSD. Just because you don't meet full threshold PTSD doesn't mean that you don't have significant PTSD symptoms. And there's a whole literature about subclinical or subthreshold PTSD. That's the thing. So a lot of progress has been made in my lifetime, certainly, about this, but treatment recommendations remain undeveloped. So it led me to work on, well, if it were up to me, what would I recommend? And I've been thinking about this and recommending stuff about how to approach these complicated cases since 1994, almost 30 years. I wrote a first set of brief guidelines. So this is my latest rendition. And don't get scared, this is complicated. And again, I invite you to get this paper. It's readily available online, it's open access. It's in the it's in Frontiers in Psychiatry. It just got published May 12th. It's hot off the press. And so it's not rocket science, but I'm kind of this is my recipe for what integrated treatment looks like and treatment planning looks like, starting with assessment, Diagnosis is important, y'all. It's not the end-all be-all, but if you make a misdiagnosis, it takes you off on a wild goose chase and you don't deliver the correct treatment. Whether you're bipolar or unipolar matters. Whether you have DID or bipolar disorder or schizophrenia matters, right? Whether you have ARFID or anorexia nervosa matters, right? There's so many ways in which diagnosis matters. Whether you have major depression or a brain tumor matters, right? Because the treatment's going to be different. What do you do after you do that? Well, educate. Psychoeducation is the cornerstone of every evidence-based treatment. And so in order to educate your patients, you have to educate yourselves. You have to know about all of the conditions that you're diagnosing. And if you don't know about it, what I do is I go and learn about them. I've had plenty of cases where there's a new condition that I knew nothing about, but I went and learned about it because I think I have an ethical obligation to that. And of course, the first order of business is establishing safety, doing detox when detox is indicated, inquiring about readiness for change, because some people are ready to change some things and some aren't ready to change other things or anything at all. So that's an important component before you can really move on. And in eating disorder cases, restore or stabilizing weight, normalizing eating, monitoring behavior. And then when you've got eating disorders and PTSD, one of the things I've been talking about is building the bridge. What are the adaptive or functional links between these symptoms? Just like I was talking about the role that binge eating plays in dealing with PTSD symptoms. That's an adaptive function. And people in psychodynamic psychiatry have been talking about adaptive function for years. And so that's still important to understand that and often patients don't see these connections. So that's part of the therapy, is helping them see these connections and links between events, symptoms, behaviors, and disorders. And doing a timeline over time can help it become a visual, kind of a visual representation for them. And then you're prescribing some form of integrated treatments. And these are all evidence-based treatments. And the cognitive processing / exposure treatments are particularly important for trauma-related disorders, PTSD. And my bias is cognitive processing therapy. There's also prolonged exposure with cognitive behavioral therapy. There's also trauma-focused CBT for children and adolescents. There's some EMDR, there's writing exposure therapy, there's narrative exposure therapy, there's imaging rescripting, which is really popular in Europe and the Netherlands, a form of exposure treatment and cognitive restructuring. And there's compassion-focused treatment that's also used much more in Europe in these conditions. And then a combination of DBT skills, particularly mindfulness and helping people learn how to regulate their emotions, helping them learn how to breathe, identifying what's important to them. Family work is always great if you can add it. IPT has been interpersonal therapy, elements of that have been helpful for people with depression as well as PTSD. 12-step facilitation, not just going to meetings. That's never been shown to be helpful, but 12-step facilitation, a manually driven therapy for alcohol use disorder and other forms of substance use disorder has been shown to be helpful. And then yoga, meditation, other types of body work, not to mention psychopharmacologic treatments. So with that, you get some reduction or resolution of comorbid symptoms, and you're assessing every which way along the way, and you're moving toward abstinence / harm reduction. And harm reduction is a really important concept that began in the addiction world, but has application also in treating these complex PTSD individuals. It has major implications for food addiction. We're not talking about caloric restriction. We're talking about altering the types of foods that you eat, which there is a wealth of literature, and there's a whole body of nutritional psychiatry that has emerged. There's a journal now called Nutritional Psychiatry, where what you eat matters in terms of brain function, positively and negatively. So why CPT? Well, it's evidence-based. It's a frontline treatment for PTSD. It's used in the VA. It's backed by numerous randomized controlled trials. It's training friendly. It's transdiagnostic. It's efficient. It's flexible. And it's applicable. And it's a lot of what you know already if you've done any psychotherapy training. It's just a type of cognitive processing. It's a type of cognitive behavioral therapy that's geared specifically toward PTSD. And a lot of the concepts are really the same that you've already known. And why CPT? Well, because the research has been done in the eating disorder field, largely done by Catherine Trottier in Canada, along with Candace Monson, one of the original authors of the CPT manual, with Patty Resick, and then Steve Wunderlich and Ross Crosby at the University of North Dakota and Sanford Research. And this paper came out in 2022, and it's a controlled trial of integrated cognitive behavioral therapy for eating disorders, which includes CPT. They didn't call it CPT, but that's what it is, integrated into eating disorder treatment versus non-trauma focused. And you can see there was a much stronger preference for integrated treatment, and the ones who got the integrated treatment did better. And she had a pilot study before this that showed the same thing, that it was really helpful. And so this is the only randomized controlled trial in this multi-morbid population. So you change through accommodation. You're creating change in belief structures, like you do in any kind of cognitive behavioral therapy, but it incorporates the trauma in a realistic and balanced way. It focuses on 5 themes that you can remember with the mnemonic SPITE: safety, power, control, intimacy, trust, and esteem. Those are the 5 biggies that you're going to deal with when in the psychotherapy of individuals with trauma and PTSD. And there are 3 major therapeutic tasks, 3 things. Whatever you do, use these things, these principles. Avoid avoidance. Do not collude with the patient's avoidance, because that's one of the big clusters of PTSD symptoms. Avoidance. You're not helping them. And people rationalize all day long why you shouldn't do trauma work. The only contraindication that has come up in the literature for doing trauma work, whatever the type of trauma work you do, is suicidality and a life-threatening condition. That's the only contraindication. It's not anorexia nervosa or substance abuse or they're too upset, or you can begin to assess for it and you can move forward. And then the third principle is Socratic questioning. If you don't know what to say, ask another question. It's a classical psychiatry move, right? You ask another question, right? Get more information. Peel off the layers, right? You can't have too much information. That's a saying I've told residents. You can't have too much information. Find out more if you don't know, right? So what about treatment outcomes? This approach has been instituted at Montanito, and we published our follow-up paper with over 609 patients, mostly female, about 26 years old, 22% LGBTQ, with and without PTSD. And they completed a lot of the assessments I've showed you. We controlled for the number of days between admission and follow-up. And we saw significantly higher scores in the PTS group on all measures at all time points. So PTSD makes people more severe, but it doesn't mean that it can't get better. It does get better, and it is treatable. So they showed similar symptom improvements. The only thing that got worse between discharge and 6-month follow-up was depression. The only thing. Everything else got better and stayed better. And there were no PTSD time interactions. This is the eating disorder examination questionnaire. And you can see significant difference between admission discharge, and it stayed different at follow-up regardless of the presence of PTSD, even though PTSD folks had more severe symptoms. The same is true for the eating disorder inventory scores, exact same. These are almost superimposable, these graphs. The same is true for eating disorder quality of life, right? Their quality of life improved, and it stayed improved at 6 months after treatment. And then the Spielberger state anxiety stayed better, and I don't have the trait because it looks exactly the same, right? Got better and stayed better. And this is the depression, the PHQ-9 score. The depression got better, and then it got a little worse in both groups, although it's still significantly better than it was in admission. So chronic depression, and in the longitudinal 22-year follow-up that Harvard did of eating disorders, the one thing, the major thing that was predictive of non-response was the presence of major depression. So depression is a big deal. And as I said earlier, the great majority of people coming into treatment at higher levels of care have a significant mood disorder. So that's a real challenge. So age of eating disorder onset were significant covariates. And so the earlier the age of onset was a negative predictor, as well as higher BMI. And then we did conclude that integrated treatment approaches can be successfully delivered in residential treatment and are associated with sustained improvements. Thank you, that's it. I appreciate your attention.
That was amazing. Thank you very, very much.
You're welcome.
For anybody who has questions, we'll stick around for the next 10 to 15 minutes to field those questions. So we can start in the room. Anybody in the room? Yes.
With the cognitive processing therapy, maybe 6 months ago I was looking at it because PESI does a lot of trainings on this model.
Yes.
So I was looking at it possibly for my staff. We've been kind of looking for a core model to use, and we primarily work with children and teens. Mm-hmm. And in the research I had done, and it may have been inadequate, it didn't seem like that model was as focused on younger teens, maybe older teens, but not younger teens and children. And that's why I didn't go that direction. Do you have any thoughts on that? Like, is it a good model for, let's say, the young adolescent population, or even down to early childhood?
Let me repeat the question. So the question, just to repeat it for those virtually, would CPT or cognitive processing therapy also be a good treatment for younger adolescents, children and adolescents?
Yeah, it's hard to make a definitive cutoff because of just changes in development or differences in development, but it has been studied in older adolescents, like 16 and above, and you can get away with it a little younger than that if people are intelligent and able to understand the questions and grasp the concepts. But it hasn't really been studied in adolescents younger than that, so it's variable. The approach that overlaps a lot with CPT is trauma-focused CBT. And that has been studied in children and adolescents from 8 to 18. So if you're wanting something that's applicable to children, then I might look at TFCBT. But CPT can be used in older adolescents for sure.
Okay, we'll go to one from the virtual audience. I'm wondering about differential diagnosis, instead of understanding people as having many diagnoses, or many, they have all of them that they meet criteria for. So how do you determine, what is actually a comorbid or a multimorbid condition or not?
Yeah, it gets confusing.
Yeah.
So I'm big on assessments. I didn't spend a lot of time on that, but I think if I'm confused about what a diagnosis is, and there are many diagnoses, I use very much structured clinical interviews. I will use the structured clinical interview for DSM-5. I will use the kitty SADS if it's a child or adolescent. I will use the dissociative disorder interview schedule if I suspect a dissociative disorder. So that is how I ferret out what all the different diagnoses are, because I think it's super clear. It's a really important first step, as I said earlier, to determine what the best treatment plan is. You need to know what problems you're dealing with first.
Okay. Another question from the virtual audience. First part of the question is, what are the definition and diagnostic features of food addiction?
I don't know that I can recite all of the diagnostic criteria for food addiction. It's straight out, the Yale Food Addiction Scale, the modified Yale Food Addiction Scale 2.0, which has been modified to match criteria for criteria, the DSM-5 diagnosis of an addiction, of what an addiction is. So it's easily available. Ashley Gerhardt has that on her website. And you can download packages to get the modified Yale Food Addiction Scale 2.0 and learn how to score it. And you can read their 13 questions. And some of them deal with craving and how much time out of your life pursuing these substances takes. There are several, but they're exactly the same criteria that you use for every other substance use disorder in the DSM.
Another one is, how could you treat food addiction in somebody with an eating disorder without perpetuating dieting and diet culture?
Yeah, that's a good question, and I'm not saying that we know how to treat it. Part of the problem is because people have been refusing to do the research in eating disorder communities. And we need to incorporate that into our measures so that we can learn how best to treat it. But what's clear is that one size does not fit all, and that a lot of patients have come to me telling me that they have food addiction. And so having a conversation about the pros and the cons of not eliminating but reducing certain types of foods in their diet that they may have particularly trouble with, that they feel really out of control. There are some people that just cannot keep ice cream in their house because they will literally eat the entire carton, no matter what. And so you want them to be able to eat, ideally, ice cream in moderation, right? But they don't, and they feel that they can't, and that's the definition of both a severe binge, the lack of control of eating, and it's also a criteria for food addiction. And we know Yale Food Addiction Scale score is a proxy for severity of binge-related eating disorders as well as some other comorbidities. So I think you have to have a conversation and have all possible options on the table. And I had a patient like that who had DID, and she couldn't not eat ice cream. And we discussed it. Does it make sense not to have ice cream in your house? And she couldn't do it. And she continued to binge on ice cream, no matter what other measures she tried to implement in terms of reducing the amounts or buying smaller cartons. It remained a problem, and she was just not willing to give up eating ice cream completely, right? And I love ice cream, but you don't have to eat ice cream to live or to have a healthy diet. So it's a tough one. Yeah. And again, we need more research. Hear me well. We need more research on how to treat food addiction. There are conditions that are identified. That doesn't mean we know how to best treat them. And this is one of them. We didn't know how best to treat binge eating disorder when it first came out. We didn't know how to best treat bulimia when it first came out. We did the studies.
One question that I have on the residential eating disorder follow-up study that
Yeah.
you did,
Yeah.
why do you think depression got worse at 6 months?
Yeah, we really don't know. We did find that earlier age of onset was associated with less response. We did find that
Onset of ED or PTSD?
onset of eating disorder.
Okay.
Yeah. So they have worse prognosis. They have higher rates of depression. They're more severe, so that may be one factor. Higher BMIs, and again, that gets into the whole issue of the biological embedding that you can have with trauma that results in larger bodies in certain people. There's a rich literature showing that association. It's certainly not the only cause. There's a major genetic piece as well in terms of our body size and shape. But trauma is certainly been shown to be an important variable.
I have another question in the room.
Yeah.
Cognitive processing therapy has manualized as like 12 weekly sessions, right?
Yes, that's
Do
right.
you think it's something that could be condensed into like a 3-time-a-week group-based therapy that's still manualized but is more condensed into like 4 weeks or so?
So
repeat that?
cognitive processing therapy is a manualized 12-week therapeutic intervention. Is it possible to condense that either in group format or individual format more frequently than once a week?
Yeah, good question. Yes, you can condense it, but I don't recommend that you do it in a group format. And programs have tried, and it makes sense to give it a shot, but it's too disruptive for other people to hear other people's traumas, generally. So you can do part of it, and you can do a lot of the education, the psychoeducation, and you can do some stuck point work and some of the didactic parts of CPT. But in terms of doing the impact statement and in some cases the narrative, that doesn't go over well in group. It's too triggering for people, and people go at different paces. And everybody's not in the same place in the manual. And then when you have a program, you have people joining at different points, so it's staggered. And you know, if you had, and I know programs who have tried that, and they gave it up because it didn't work well. But you can certainly accelerate CPT, and you can get it all done in 1 week. There's a famous podcast about a person who was unresponsive to PTSD, and she went and saw a therapist, and they did CPT every day for 2 weeks.
It was on This American Life, I think.
Yeah, you know what I'm talking about. And she had a wonderful experience and got completely better from her PTSD. And so you can do that, but better on an individual basis.
I used to work at a facility that did intensives, like 4-day
Yeah.
intensives with
Yeah.
5 or 6 people.
Right.
But everyone did stay together,
Yeah.
obviously, and do it all sort of the same.
And how did that work?
Their research showed that it was impactful. I think it's Dante Center for Healing. I think they are still doing it.
Okay.
The weekend intensives, but it was often like people in residential. They pulled them from programming and sent them to do this for
Yeah.
the weekend, or some people from the outside as well. And they did the PCL before and after.
Yeah.
And I mean, within 4 days, I don't know long term how well it worked.
Right. Yeah.
Great.
Thank you.
Any more questions in the room? Okay, we are at the 12:15 mark. You're all invited to stay and converse and connect and eat some lunch. And just one more big round of applause for Dr. Brewerton.
Thank you.